Well, thank you very much, and thank you everyone for hanging in there. We hope to make this a really interesting last session for all of you, and we're really going to focus on what's been labeled as societal approaches to this problem. So the title that I was given is Can We Use the Evidence, Please? And I'm happy to really talk about this because although I don't like to disagree with my esteemed colleague Patrick McGrath too often, I've been disagreeing with him for the past 20 to 30 years, so he won't be surprised because I do think we have a problem with knowledge translation, and I'm going to talk about that a little bit today. So this was a paper that was written in the mid to late 1980s, and it said surgery without anesthesia can preemies feel pain. So this dates back about 30 years now, and we probably couldn't even imagine that people would ask this question today, but it was certainly commonly believed that back in the 1980s that babies did not feel pain because their nervous system was not fully myelinated. And so babies had procedures done, including surgery, without any type of anesthetic or analgesic. If we fast forward by 30 years, we now can see that people are really not only believing that babies experience pain, but also that pain is associated with alterations in the brain and can lead to both behavioral and cognitive disabilities down the line. So we've made quite a lot of strides in increasing our knowledge base through a lot of research done at various aspects of the spectrum, from basic through to clinical research. In fact, this was a recent review that was done by Lena Case, where she looked at the increase or growth in pediatric pain research in 5-year blocks, and you can see that there's been exponential growth in the evidence around pain research in children. However, getting the results of that research into practice is not easy, and it takes a long time. So you can see here that it's been estimated that it takes approximately 17 years from the time of original research until the time that that is implemented into practice. And for those of us that work with children, that's whole childhood. So we really need to look at this, and although we may think it's intuitive that we read the research, we take the results, we implement them into our everyday practice, that is not usually done. But we can't really ignore this issue. We have an ethical imperative for getting what we know into what we do, because there's results, there's consequences of not doing this. And if you just look at this is a compilation of studies where we've learned that patients don't get treatments of proven effectiveness. They don't have the information that they need to make decisions. Some of them get care that is not needed or potentially harmful. And up to a half of physicians don't have the information they need to help patients make decisions. So we have an ethical imperative to get the results of this research into the hands of a variety of stakeholders. So where does knowledge translation happen in science? Well, we know that it actually can happen at a variety of different junctures. So it can happen between basic science and clinical science. It can happen between clinical research and clinical practice. And it certainly can happen in the scale up or spread of research across populations, settings, systems. And how do we do that? Well, we have many models that can guide us, and I'm sure most of you are familiar with the Canadian Institutes of Health Research Knowledge to Action cycle. And you can see that in the middle of this cycle, We have the focus on knowledge generation, and this is where the knowledge inquiry happens and is then synthesized and is then produced in tools such as guidelines, websites, resources, that kind of thing. But this doesn't happen without the process of knowledge translation. And knowledge translation is really putting something into a way of understanding that the knowledge user can use it. We often think of knowledge translation as being mostly for healthcare professionals, where the goal is to change their behavior. But in actual fact, we have multiple target audiences that range from patients and families to healthcare professionals, to managers, to decision makers, to policymakers, politicians, the public, society at large. So that is the issue with knowledge translation. It is not a one solution kind of thing. We have to consider who the target audience is, what the key message is, the strategy that will work the best for them, and then we can evaluate it. And we do have experts in the area of knowledge translation or implementation. Some of them are sitting in this room, and I would challenge us to think, we've heard multiple times today that getting what we know into practice is a challenge, but I don't think we've really acknowledged the challenge that we have in doing that. So where to next? It's not surprising that I'm going to say that we really need to increase our focus on implementation science, which can be divided into implementation and dissemination of research evidence. We really need to continue to focus research on pain, on prevention, integrated management therapies, and the barriers and facilitators to knowledge uptake. We need to really think about tailoring that knowledge for the user, for the system. Focusing solutions at the systems level as well as the individual level. Tailoring the messages to stakeholders, especially decision makers and policy makers. We need to educate early and often and include patients and families in the solution. And I'd just like to end, this is the University of Toronto Centre for the Study of Pain interprofessional or interfaculty pain curriculum, where every year we educate 1,000 undergraduate students or pre-licensure students on pain in a novel 20-week curriculum. And I think this is really trying to address that statistic that we heard earlier, that veterinarians get more education on pain than health scientists do. So I'll stop there and thank you very much.